Hello, my name is Scott Roberts. I'm a professor of health behavior and health education at the University of Michigan School of Public Health, and I'm going to be speaking to you today about genetic testing for Alzheimer's disease. Just to give you a quick overview of what I'll cover in this talk, we'll start with talking about genetic factors in the development of Alzheimer's disease. We'll then look at specific types of genetic testing relevant for Alzheimer's, including how genetic counseling can be important as an adjunct to this genetic testing. We'll highlight some ethical and policy issues raised by genetic testing, and then close by talking about some future directions in the field. So before I specifically talk, though, about genetic factors involved in the development of Alzheimer's, just a reminder that Alzheimer's is a multifactorial condition. So even though genetics plays an important role, of course, there are other factors that help either cause or lower risk for the disease. And I think the protective factors are important to highlight because when we do genetic testing and we give people risk information, it's also important to emphasize that it's not destiny, that it's not inevitable that they will get the disease, and that there are things that one can do to lower one's chances. And of course, a lot of these also overlap with what can be done to reduce risk of conditions like heart disease. So there's a slogan that you may have heard about called "What's good for the heart is good for the brain." So the upshot of this slide is basically that genetics is important for Alzheimer's, but because it's a complex condition, it's not the whole story. Genetic testing, of course, is a many-splendored thing. There are many different types of genetic testing out there that are used in clinical practice. You can see some of the different types listed here. The ones listed in bold are the ones I'm going to highlight today because they're the most relevant in the context of Alzheimer's disease. And you might wonder, well, what's the difference between predictive and susceptibility testing? Well, these are both types of testing that are used with at-risk populations to say more about their risk of developing the disease. It's just that susceptibility testing is much less predictive than predictive testing. So I'll talk about this, but susceptibility testing is more just to identify elevated risk, whereas predictive testing gives pretty much a yes or no answer usually as to whether one will develop a given condition. And so, for example, genetic testing for Huntington's disease is a type of predictive testing because those with the mutation almost inevitably go on to develop the disease. So when we talk about genetic factors in Alzheimer's, in the 1990s was a major period in genetic research in this area because multiple mutations were identified that almost inevitably cause Alzheimer's if they are present in a given person. So these are what are listed here as these known mutations. So the presenilin 1 and 2 genes on chromosomes 1 and 14, as well as the amyloid precursor protein on chromosome 21, those are rare, very rare mutations, but highly penetrant, meaning that they're highly associated with the ultimate phenotype of Alzheimer's disease. Another type of genetic marker that's worth noting here is ApoE, found on chromosome 19, which is called a susceptibility polymorphism because it's important in terms of Alzheimer's risk, but less predictive than those known mutations listed above. So when we talk about those known mutations, they can be used for predictive testing for Alzheimer's disease. So those three genes that I mentioned earlier, the presenilin 1 and 2 and the APP, we do have clinical testing available. And this is because there are some families where these mutations are present, and in those families, even though they represent probably less than 5% of all Alzheimer's cases, you can often see very prominent family histories of the disease in those cases, and often even with early disease onset. So sometimes you hear stories of people with these mutations who are developing symptoms even in their 30s and 40s. And then unfortunately, in those cases, the disease tends to progress more rapidly than in what we call sporadic Alzheimer's disease. And it's also important to know that these mutations are passed down such that if we have an effective parent with an identified mutation, there's a 50-50 chance of passing it on to their children. So if you ever saw the movie Still Alice depicted here, this is Julianne Moore won an Oscar for her portrayal of a woman who did have a rare mutation that caused Alzheimer's in her 50s. And so the film talks about should her adult daughters get tested to learn of their risk. And it's often a tough decision because we can't necessarily do anything that will truly prevent the disease as of yet, and yet some people would like to know for planning purposes. And so in those cases, we do have genetic testing and counseling available at specialty clinics for family members who are interested in learning whether or not they have one of these mutations. But again, this is not relevant to broad swaths of the population because the mutations are so rare in the general population. But for example, at the University of Michigan, we do have an adult genetics clinic where patients are seen and then can get counseled to decide whether or not they would like to proceed with genetic testing to learn if they have one of these mutations. And I think genetic counseling is important to point out because unlike a lot of other medical tests, genetic testing has implications not just for the patient, but for their blood relatives as well, because as I'm alluded to earlier, a positive test result might mean that other family members are at risk and might need to then think about testing for themselves. And so genetic counseling relies on genetic counselors who are master's level trained clinicians who have expertise both in medical genetics as well as patient education support. And so they can be very valuable in helping educate folks about what genetic test results will mean, what their implications are, and what next steps to take should be. And so they can really be a great aid to informed decision making in this context. And so what usually happens is that genetic counselors ideally meet with people beforehand to provide pretest education and to help people think through what are the implications of genetic test results for them and their family. And again, it can relate to planning for the future. It might inform healthcare decisions. It can inform other major life decisions like marriage or childbearing. And so given the stakes are high here, genetic counselors can provide this pretest education to help people decide, do they really want to go through with the test? And then on the back end, genetic counselors can be helpful in disclosing results, providing information about what the results mean, providing some initial support in coping with the impact of the information, and then providing recommendations for next steps. Unfortunately, there's not a lot of genetic counselors in the United States, just several thousand as opposed to tens of thousands of nurses and social workers, for example, that we have. And so sometimes access can be a challenge given the limited numbers. But I think we're seeing genetic counselors try to expand their reach through things like telehealth and other services. So it's not just within specialty clinics. So that's a little bit on predictive testing for Alzheimer's and for those rare, highly deterministic mutations. Let's shift gears a little bit and talk about susceptibility testing. And when we talk about susceptibility testing, we usually are talking about testing for the ApoE gene that I mentioned earlier. So again, this is a plasma protein on chromosome 19. And we all have an ApoE genotype. And we inherit one allele from each parent, and it's usually comes in three types. So we inherit either an E2, E3, or E4 allele from each parent. And it's the E4 allele that's the well-established risk factor for Alzheimer's. But it's important to know that an E4 allele is neither necessary nor sufficient to cause the disease. So for example, if you have an E4 allele, it's not for sure that you'll go on to develop Alzheimer's, and you could have Alzheimer's but not have the E4 allele. And to make matters even more confusing, ApoE is also relevant for other health conditions as well beyond Alzheimer's. So E4 is not just a risk factor for Alzheimer's, but also a modest risk factor for heart disease. And interestingly, the E2 allele is a risk factor for a certain type of hyperlipidemia, but it's actually protective in the context of Alzheimer's. So you can see why genetic counselors can be useful, because this can be pretty complicated information for patients to digest, and particularly when you're talking about test results having meaning for multiple medical conditions at the same time. Now, how many E4 carriers are there in the general population, you might ask? Well, you can see from this table here that over 25% of the general population carry at least one E4 allele. And so that makes it a relatively common genetic risk factor as compared to the rare mutations I was talking about earlier. And you can see that about 2% of the general population have two copies of E4. They're what we call E4 homozygotes. And so having two copies of E4 elevates your risk even beyond what one copy does. And so to put some numbers to it, you can see that the general population risk of Alzheimer's is estimated to be about 10 to 15%. And you can see that E4, if you have one copy, elevates risk to about the 20 to 30% range, and that two copies elevates it even further, such that you may even go beyond a 50-50 chance of developing the disease. So from these numbers, you can tell that E4 is an important risk factor, but you can also see, as I mentioned earlier, that it's neither necessary nor sufficient to cause Alzheimer's. So it's not quite as predictive as the rare mutations I was talking about earlier. So ApoE testing has been possible since the 1990s, but there's been a lot of controversy over, well, should we even go forward with this in medicine? And to make matters even more interesting, in more recent years, we've seen how ApoE can not just predict risk of Alzheimer's in asymptomatic populations, it also seems to be associated with higher risk of Alzheimer's in people who already have mild cognitive impairment, as you can see from this figure here. So I mentioned that susceptibility testing using ApoE genotyping is controversial. It's not recommended generally for use in clinical practice, and I think that's because of two things. One, I mentioned it's limited in terms of its predictive value, but also we have notable limitations in our prevention and treatment options for Alzheimer's. So given that combination, the idea has been that given there are potential harms from learning this information, for example, people might become distressed from learning they're at high risk for potentially fatal severe disease like Alzheimer's. There's also broader concerns about genetic discrimination and stigma. Might people be treated differently if others learn that they are at elevated risk for Alzheimer's? So because of these concerns, we have not seen clinical practice adopt ApoE genotyping to a great extent. Now, that being said, there's still a lot of interest out there in the general public about this information, particularly for those who do have a family history of Alzheimer's. So there's a lot of people who say, well, yeah, it may have its limitations, but I still think I would rather know than not know. Sometimes this is for practical reasons to inform advanced planning or decisions, but oftentimes it's just a more general notion that people have that just knowledge is power, and I would rather have this information than not, even if I don't have any specific plans to use it right now. Things have gotten really interesting in the direct-to-consumer genetic testing space. You may have heard of the company 23andMe. And so even though ApoE testing is not generally used in medical practice, it is available through companies like 23andMe, who got FDA approval for the ApoE test back in 2017. And so this means that given that 23andMe has millions of customers, there's a lot of people learning their ApoE genotype, even though they may not that might not be the primary reason they signed up for the service in the first place, because 23andMe if you know anything about the company, offers all kinds of genetic information relevant to a range of health conditions, but also relevant to ancestry as well. So a lot of interesting ethical debates over how ApoE testing should be done and whether people should be doing this in a direct-to-consumer format where it does not have the genetic counselors involved that I mentioned earlier. And so because of some of these concerns that I've alluded to, the American College of Medical Genetics and the National Society of Genetic Counselors back in 2011 put out practice guidelines that again discouraged ApoE testing both in direct-to-consumer and in medical context, given its limitations. But I think at this time we didn't have a lot of data on the pros and cons of doing this, and I think since then we've seen a lot of research studies look at the process and impact of ApoE disclosure, including our own group here at the University of Michigan. And other groups have also done good work in trying to help people think through this decision. So here, for example, is a website called genetestornot.org. That's an online decision aid developed by a team at Virginia Tech, basically saying if you're interested in ApoE testing, you may want to go through this online decision tool to think through the pros and cons of ApoE testing. But I mentioned our group has done controlled research studies where we've offered people the chance to learn ApoE results. Typically, this has been people with a family history, for example, an affected parent with the disease. And we've done several studies in this area, and over time, we've found that participants have generally understood the meaning of their test results and fortunately have not experienced clinically significant distress. And of course, this has been in the context of having genetic counselors meet with them to explain the findings. So this is not direct-to-consumer style, but in the way we've done it, it does seem that even if you get quote-unquote bad news, learning your E4 status, for example, it has not typically resulted in people becoming significantly depressed or anxious as a result. We've also done some work in trying to offer this kind of testing in a more streamlined approach, so not using a highly time-intensive, labor-intensive genetic counseling model. And fortunately, we found that you can disclose this information safely and effectively in formats like telephone disclosure or with briefer pre-test education sessions. And we found that test results have prompted an interesting range of responses. Sometimes people have engaged in specific health behaviors like diet or exercise to try to lower risk of disease. And sometimes they have made changes in their advanced planning, for example, long-term care insurance. And I think some of these behavioral responses raise some interesting ethical and policy issues of their own. So, for example, one change that we found that several people made was to add some kind of vitamin or supplement if they learned they were at elevated risk. And I think this raises the broader issue that we are now seeing the marketing of a lot of anti-aging nutraceuticals. You can see some of the products listed here. And I think the concern I have is that some of these products are making claims that have not been as rigorously evaluated as, for example, by the FDA, as when we see prescription medications make claims about treatment. So you can see products that say, you know, they support memory function or nutrition for the brain. I think we need to take these with a grain of salt. Not to say that these are harmful products, but just worries that that some of these may be exploiting fears that the general population has about one day developing Alzheimer's. Also, I think it's important to recognize when we talk about ApoE results is this possibility of genetic discrimination. So I think people who are undergoing ApoE testing should ideally know that there are legal protections out there that might be useful for them. So for example, the Genetic Information Non-Discrimination Act, known as GINA, was passed back in 2008 in the Bush administration, And this law prohibits the use of genetic information by both health insurers and employers. So, for example, it's illegal for a health insurer, if they're trying to set a premium or who should be covered, if they use genetic information to deny someone coverage, for example, that would be illegal under federal law. Similarly, employers are prohibited from using genetic information in decisions like who they should hire or who they should promote. And so it's good that we have these protections on the books. But it's also worth noting that GINA does not extend to other types of insurance beyond health insurance. So it does not cover long-term care, disability, or life insurance. And so long-term care may be the domain that's most relevant for Alzheimer's, where if people use ApoE testing to inform their long-term care purchases, they should recognize that GINA protections do not extend in that realm. Now, genetic testing, I've talked a lot about in clinical and direct-to-consumer contexts, but of course it's done all the time in research studies. ApoE testing, for example, is a standard part of a lot of protocols following people in Alzheimer's research. And so this genetic information is routinely collected, and typically people are not getting those results back. But even though a lot of times they're interested in this information, the practice has usually been in research to say, hey, this is not clinical practice. Research is about generating generalizable knowledge, and so that individual genetic results are not being disclosed. But I think we are seeing a little bit of a trend of sites to actually consider this. For example, the National All of Us study is now returning genetic results, and sites around the country are starting to think about, might this be useful to keep people engaged, particularly if it's a longitudinal study? Might it be a way of giving back to people who are volunteering their time? And so I think this is an interesting debate to have over whether and what type of genetic results should be returned in research studies. Another way genetic testing is relevant to research studies is it's now becoming a key part of determining who's eligible for major prevention drug trials. So you can see some of the major prevention trials that have been undertaken in recent years. Some of them use biomarker findings, but several of them do use genetic testing. So, for example, the DIAN study that some of you may know about, the Alzheimer's Prevention Initiative, the Generation 1 and 2 studies, they've used different types of genetic testing. Some have used testing for those rare mutations that I mentioned earlier, but some, like the Generation 1 and 2 studies, have used ApoE testing. In those studies, for example, to be eligible, you have to have 2 copies of that E4 allele I mentioned earlier. And the rationale behind this is that genetic testing can be helpful in identifying high-risk groups for prevention trials where you would have to follow them for shorter periods of time, and you might need fewer participants than if you took all comers, for example. So it can be a way to enrich populations for risk of disease to make prevention trials less time-consuming and less costly, which of course is very important given how expensive and time-consuming they generally have been. Now, unfortunately, like many other studies, the prevention trials that have used genetic testing have not necessarily had positive results. So I mentioned earlier the Prevention Initiative, a very interesting study of mutation carriers in Colombia, South America, just recently reported that the drug they were testing, crenuzumab, did not have a differential effect over placebo for the patients enrolled in that trial. So this was a decade-long study with 169 asymptomatic Colombians who did have a rare disease-causing genetic mutation, although in this study they were actually blinded to that status, and they tested an anti-amyloid therapy, and ultimately the therapy was not shown to have a significant benefit compared to the control group. And so along with a lot of other studies, I think findings from this study are casting some concerns about this amyloid hypothesis that you may have heard about, where the focus has been specifically on trying to treat amyloid as opposed to other factors like tau or inflammation that might also be part of the disease picture. Now shifting gears to talk about other types of genetic testing. So I mentioned earlier pharmacogenetic testing. This refers to genetic tests that can be useful to inform decisions about medication, because we know that genetic differences can relate to how people metabolize drugs. And so certain genetic variants are associated with different types of response to medications. And so sometimes genetic variants might predict who's likely to not really have a good response to medication. Either it's not having its intended effect, or perhaps even worse, maybe the genetic variants might predict who's at elevated risk for concerning side effects. And sometimes you might even have a black box warning if genetic variants are associated with very severe side effects, as they can be in the context of other medications for diseases like cancer, HIV, heart disease, etc. But pharmacogenetic testing has not typically been used in the context of Alzheimer's, but it may be relevant moving forward. And the reason I mention this is because of the newly FDA-approved medication aducanumab. So even though it's a controversial medication, it still is relevant for our purposes because ApoE testing can be useful in thinking about who should potentially be prescribed aducanumab. So if you know anything about aducanumab, you know it was recently approved for the treatment of mild Alzheimer's, but it does come with the risk of a side effect known as ARIA. ARIA stands for amyloid-related imaging abnormalities. And these tend to be pretty minor usually if they do occur, but you can have some cases where brain swelling and microbleeds can lead to some symptoms like headache or nausea, or in rare cases might even cause hospitalization. But given these side effects, it might be a reason for some people to either have pause about going on the medication in the first place, or at least might bring up the need for more strict monitoring. And why does this relate to ApoE testing and genetic testing? Well, it just turns out that ApoE4 carriers are at elevated risk of ARIA. So ApoE testing might be useful ahead of time to decide whether or not aducanumab is appropriate, and or whether patients should be closely monitored for the presence of these ARIA symptoms that I mentioned earlier. And I think moving forward, not just in pharmacogenetic testing, I think another broad trend that we're probably going to see is I've talked a lot to date about these rare mutations or the ApoE4 allele, but I think there's a lot of genetic research that's identifying these relatively common but much lower penetrance markers. And so we're seeing a trend, not just in Alzheimer's, but a lot of other conditions, towards the use of polygenic risk scores, where you might see dozens of different genes used in aggregate to develop kind of a composite risk score. And so it may be that no one genetic marker predicts a lot in and of itself, but you add them all up and you can identify risk in a much more precise way. So I think we might see moving forward the use of polygenic risk scores in place of or in addition to some of the single gene tests that I've been talking about. So in conclusion, I hope I've convinced you that there are several different types of genetic testing for Alzheimer's worth thinking about, but it's important to note none as of yet are recommended as standard of care. I think testing decisions should ideally involve consideration of test benefits and risks, and to think about implications not just for the person being tested, but for their family members. And again, ideally, we might have genetic counselors or other knowledgeable professionals involved to provide this pre-test education and guidance. And I think even though genetic testing is already being used, I think it will become more commonplace in the future as our treatment and prevention options for the disease improve. So thanks for your attention. Hope this was useful for you, and I will sign off for now.